Good evening, everyone, and welcome to the presentation and graduation session for the 2024-2025 Future Healthcare Leaders Program, sponsored by the North Carolina Medical Society Foundation's Canoff Institute for Physician Leadership in partnership with the North Carolina AHEC program. My name is Manisha Thomas, and I serve as the Vice President of Professional Growth at the Medical Society. I'm joined by my wonderful colleague, Erica Neal, the Program Manager for the Professional Growth Department. Our session this evening represents the culmination of a 6-month interprofessional program, which began back in November of 2024. Throughout the program, the scholars that you'll meet tonight have had opportunities to identify their own leadership style and their own leadership behaviors through a leadership behavioral self-assessment. They got an opportunity to learn about their strengths and identify areas of improvement, and they were exposed to certain skills related to time management, communications, and teamwork. The program included 4 in-person learning sessions in Raleigh and 4 virtual learning sessions. I'll give you an opportunity to just kind of peruse the dates, and you can see how the scholars participated from November up to May during our graduation period today. This evening, you will get to hear 6 6-minute presentations on the group's team-based projects. Project-based learning is an inquiry-based educational approach that builds on one's capacity to think critically and problem solve, collaborate effectively, and engage deeply with our program's content. These team-based projects provided opportunities for the scholars to develop a response or solution based on the experiential knowledge gained throughout the program. Following each
I'm glad to hear that.
He's given a
Following each presentation, each scholar will respond to this question on your screen. They will be given an opportunity to reflect on the program and their own self-development. We wanted to take an opportunity to share with you a little bit about this specific cohort. We were so pleased that this cohort is truly interprofessional and interdisciplinary. We have students from physician assistant programs, MD and DO programs, physical therapy, and nurse practitioner, as well as a dental student. We also have quite a few universities represented, including the University of North Carolina at Chapel Hill School of Medicine, Duke University School of Medicine, Campbell University School of Osteopathic Medicine, High Point University School of Dental Medicine, UNCG School of Nursing, Wingate University Department of PA Studies, East Carolina University School of Medicine, and Wake Forest School of Medicine. Please note that we recognize that the scholars' time and your time as audience members is valuable, so we will abide by the agenda as presented. Thank you for attending this evening. We will now get ready for our first presentation, Community Engagement and Maternal Outcomes. We will give them a minute to share their screen, and then they will begin.
All right, so we're going to begin. So I just want you to take a minute and put yourself in these shoes. You can close your eyes or just kind of theoretically think, but you and your partner or family member are pregnant with their first child. You're to the moon and so excited, but then you start navigating what it looks like to be pregnant for the first time and navigating all the unknowns. And then it comes time to schedule your first appointment. But unfortunately, you haven't heard the best things surrounding births in your area, and they're kind of your only option. The next closest facility is about 45 minutes to over an hour away, and you just feel kind of unsure and discouraged. So after imagining this, this was actually me a couple years ago, and I actually drove over an hour to receive care at a facility I'd heard such positive things about and had thankfully a great experience. But the question is, why can't we bring this kind of to everyone, especially in rural North Carolina?
So, with all of our interests in obstetrics, along with Callista's experience, we wanted to investigate why rural OB care is such a struggle. As we began our research, we found 14 rural hospitals in North Carolina have stopped providing maternity care in the past 10 years. We decided to focus our project on Watauga County specifically, where Callista had her experience. On the next slide, you'll see a map, and the areas in yellow have sustained or grown, but the areas in red or in blues have all either been reduced, eliminated, or never provided service at all. Labor and delivery units are known as hospital business loss leaders due to the expense of maintaining specialized 24/7 staff, up-to-date equipment, and providing adequate space for the unit. And as hospitals see declining numbers of births in these areas, this drives up the per birth cost, which was already functioning at a loss. Most hospitals will offset the cost with higher level neonatal ICUs, but that's unavailable in the rural areas to sustain, even as they struggle with just maintaining the nursing and providers in their labor and delivery units.
So when we were looking for the solution to our problem of why is this kind of discrepancy in care, we took it to the people. We took it to the patients of the high country, aka Watauga County, and some of the surrounding counties, including Ashe and Avery. And we asked them, A, how was your experience? Did you receive prenatal care in the county? And then B, what would you do to change the care in our county and hopefully improve that morale surrounding the care? And so as you can see in our survey details, there were 43 participants that received prenatal care in Watauga County. The two that did not, the no's, they were considered high-risk pregnancies. So like Lindsay had alluded to, they needed NICU services and were had to go off the mountain. So then when we asked them what their satisfaction was, you can see only about 55% were satisfied, which we were kind of like, why can't it be 75? Like, we want more. So we asked them why. A lot of people said that they wish there had been more options. They wish they had more of a choice of who they saw, and they just wish there's more provider availability. And going back to Lindsay's map, there's just a lot of places closing down around us, so there really are no options. And so then the other thing that people said was that they felt like they weren't listened to during labor and delivery. If you've been through it yourself, you know it's such a crazy time, and it's hard with everyone coming in and out of the room, and sometimes you don't get all the information you need. And so they just felt like they weren't being listened to, or they didn't know what was happening around them. So we really toyed with the question of how can we change this? Like, how can we create more options or better patient-provider relationships and really like make patients knowledgeable about the care they're receiving before they get in that heightened time of emotion and stress.
I apologize for that. So two initiatives that we looked at to really determine to what degree the North Carolina legislature has already attempted to address this issue as it relates to providers within these areas. And what they've done is expanded the already fairly popular North Carolina Forgivable Education Loan forgiveness service, which most people can appreciate within the scope of the teacher fellows and the degree to which that supports primary education within the state of North Carolina. So the idea behind this was $25,000 a year for those students, medical students pursuing OB-GYN, psychiatry, internal medicine, family medicine, and pediatrics, as long as they serve 1 year for a loan within a Tier 1 or Tier 2 county within the state of North Carolina. The other thing beyond just this was some success that we saw in Chatham County. The family medicine component of UNC Chapel Hill was responsible for establishing a labor and delivery unit of 5 beds in Chatham County, which was able to provide a service at a critical access hospital.
So what's our solution? When we went and started looking for birthing classes and to see what was available in the county, we had kind of a difficult time figuring out how to receive access to those, and even just availability was super limited. So we said if we could consolidate this resource and make it really easy to access so that all women, specifically in the high country, could have access to a birthing class, then perhaps that would be our solution. That would have a ripple effect and improve so many things that Lindsay and Mark are going to tell you about.
And the patient-provider relationship would augment that. So a lot of these resources would include the providers that were already within these regions, so that not only would you see them at their appointment, but these resources you would see on your Reels, YouTube Shorts, and all of the informational handouts that you have. And then diving into determine to what degree can we assess is this North Carolina FELS program supporting the overall goal of putting providers in high-need communities for a long duration of time and enhancing continuity of care.
Lastly, we want to take advantage of social media platforms. People spend so much time scrolling, laying in bed at night. So we would like to improve health literacy by creating short videos or even longer YouTube playlists that can increase access to health education, give procedural expectations, and just answer common questions or concerns. These videos can familiarize the patients with their local staff, which will also alleviate some of the uncertainty that comes with pregnancy. And you'll have accurate medical information directly from the providers you'll receive care from.
So as we get to questions, like Monisha said, we were asked to reflect on some of our most valuable insights on our leadership journey, especially pertaining to this program. For me, it was within my DISC leadership style, realizing that it was steadiness and influence, which part of that is being very even-tempered, wanting to be accommodating to others, and just an optimistic presence overall. And I do see that when I am in a group setting. And I found that I could improve myself by building my confidence in how I lead and being first to speak up in some circumstances, even if it might step on toes or might not be the popular opinion, and knowing that it is valuable and overall it's going to help in our group growth and development.
I also got the biggest insight from the DISC profile. I am on the other side of the spectrum where I am more direct and strong-willed and driven personality. And so I used the DISC profile to make my personal development plan, where I focused on considering the impact of my words and then accurately completing things on time instead of rushing through things. And both of those have had huge impacts positively on my current clinical rotations.
I would say mine was kind of a change from what I'd previously thought. In the military, I thought that discipline, ability to grind and establish consistency for a group was the way to lead, if not lead by example. And I would say my DISC profile showed me that is true, that I do have that strength, but that I'm more of an I. And so my strengths that come most easily to me are bringing group cohesion together, having being the dreamer and finding a way to help those Ds and those S's to feel like they're included in the group and that we can drive towards the end.
Are there any other questions from anyone?
Callista, thank you so much. Thank you, Lindsay and Mark. I'm going to interrupt just because we want to make sure that we stay on topic and time. The next presentation is scheduled to start at 6:16. We will come back and have questions from the audience if there is time. But thank you all so much for mentioning the DISC profile. We will now go to our next presentation, and we will have Alex share his screen. And Alex and Nesreen will be up next. Alex? And we are placing the agenda in the chat so that you can click on that, and that will help you sort of follow along with us, just in the interest of time.
And
All right, can you see my slides?
Yes, we can. And for those that are participating, feel free, if you have questions, to drop them in the chat so the students can prepare towards the end if need be to answer those.
All right, so we're going to go ahead and get started. So my name is Alex Nix. I'm an MS1 at UNC. And with me is Nasreen Abu Khalif. She's an MS3 at Campbell University. And today we're going to talk about mental health and the barriers surrounding mental health, for refugees and immigrants in North Carolina and the Triangle area. So refugees and immigrants in North Carolina face unique challenges when it comes to mental health, and there are multiple reasons for that. There's a widespread stigma surrounding mental health in certain cultures, so many individuals would hesitate to reach out for that. They may see that as a sign of weakness, and they don't want to be seen as weak individuals, so that might be a reason they might not seek mental health. Second, there are a lot of language barriers surrounding mental health. So nearly half of immigrant residents in North Carolina speak English less than very well, and may need interpreter services in order to be able to communicate what they're experiencing properly. Third, the cost and insurance issues arise because many do not qualify for Medicaid or employer-based coverage, making therapy very expensive for these individuals. And finally, there just aren't enough providers who are trained in cultural humility or speak the patient's language. So, for example, UNC has a program where they provide mental health, but this is specific for med students and physicians and not available for the public. And these populations are able to access this mental health very easily, but it's only restricted to these populations. So there's a difficulty having access to mental health services. So to understand the magnitude of these barriers, let's look at some numbers. So about 43% of immigrants in North Carolina speak English below the proficiency level. That alone creates huge communication challenges for mental health care. And about 50% of North Carolina's non-citizen immigrants are uninsured. So when someone lacks insurance, the out-of-pocket cost for therapy or psychiatric treatment is simply unaffordable. And lastly, mental health workforce shortage is severe. About 94 out of 100 countries are designated shortage areas. Even fewer providers specialize in culturally competent care, so the demand far exceeds the supply. So together, these statistics show just how tough it is for these communities to find and use mental health services. So why are we focusing on refugees and immigrants? Why this population? So research shows that refugees and immigrants, particularly those fleeing from violence, suffer from PTSD and depression about 30%, 30% more than the general US population. So that's a significantly large portion of this population have mental health issues. Also, they are coping with post-migration stressors like discrimination, language barriers, family separation, all of which can have a more severe impact on their mental health. And that does not only impact them individually, but also in their families and their community. So if people are struggling silently with trauma and anxiety, it becomes harder for these individuals to integrate into society properly, to succeed at work or school, and ultimately contribute to the broader community. And addressing these issues isn't just a humanitarian concern, it's essential for promoting public health and economic stability in North Carolina.
All right, thank you, Alex. Actually, can you jump to the subject matter expert slide? I want to use that to transition a little bit to our plan and solution. So these subject matter experts are agencies that provide mental health services to the immigrant and refugee populations within their communities across North Carolina, and they've developed expertise to deliver culturally sensitive, sustainable, and accessible care to their patients. And I had the privilege of working with many of these agencies during my undergraduate years in Chapel Hill and also during my gap years. And while their work is really amazing, it's very much tailored to the concentrated pockets of refugee communities in Durham, Chapel Hill, and Greensboro. They also tend to specialize in specific groups. So some will focus more on Arab refugee populations, some on Burmese, some on Latino immigrants, and so on. And then when I started medical school at Campbell, I was also given the privilege of working with more small scale initiatives that improve mental health outcomes, but in Harnett and Johnson County. And even though these communities are right outside the heart of the Triangle, it was clear that there was a lot of reinventing the wheel in terms of learning how to deliver the culturally competent and sustainable mental health care. So can we go back to slide 6, the goal slide, please? Yeah.
Is it this one?
The one after. Yeah. So putting me and Alex's experiences together, our goals are to expand the access and effectiveness of these services, to bridge existing efforts, and to focus on some of the unique needs that haven't really been addressed yet, including those of farm workers, children, and the elderly. Next slide, please. Okay, so our idea is to create an accessible and centralized resource for resettlement agencies, clinics, and hospitals to kind of come together and improve the culturally competent care that we can provide refugee and immigrant populations. Next slide, please. So this resource would be basically an online resource, a website that would consist of a resource hub, trainings and workshops, and community and provider network. The resource hub would really put together all of the expertise that's already out there on on the best practices that exist, interpreter services that exist, and culturally competent mental health care guidelines. With this platform, even healthcare providers outside of mental health specific roles can find resources as needed for culturally competent mental health care, including PCPs, OB-GYNs, and so on. Ultimately, by establishing a system of collaboration between these experts, we're not only enhancing their individual impact, but also extending their reach by making their work accessible to healthcare providers across the triangle and state, including those who work with patients in less concentrated areas of refugees and immigrants. You can go to the next slide. So again, these are some of the organizations that we've had privileges of working with and learning from. And then we're open to any questions. Thank you.
We'll hold questions till the end. And so Nazreen and Alex, if you would like to go ahead and answer the one question, telling us a little bit about the reflection on your leadership journey.
Yeah, I can start with that. So for me, it really was kind of similar to what Mark shared. It was a lot of knowing my whole life that I'm a very innovative and dreamy and lofty goal person, and learning that to channel that effectively, I need to ground myself in concrete things, including making lists and schedules and finding accountability partners so that I can structure all of my excitability into something that's practical, meaningful, and good leadership.
Yeah, for me, it's realizing that the limitations of the resources that I have in terms of energy and time, and to figure out more effectively where to dedicate those resources into the areas that matter the most.
Alex, I think you've hit on something that a lot of other scholars and those that are in graduate healthcare programs encounter. Can you tell us a little bit more about recognizing those limitations of energy and time, and how do you plan on really making that work day to day?
Yeah, so med school in and of itself has increasingly been feeling like drinking drinking water out of a fire hose. Um, so time is not only an issue that I've been experiencing, but also the limitations of my body. Like, it's easier to get exhausted and stressed and sick over and over again, like this semester, for example. And not only like I dislike when people talk about work-life balance, because it's not about separating those two, but actually integrating those two together, and finding harmony between those two, but also like recognizing that there are limits to how much your mind can sustain, and also how much your body can sustain the stresses that you're going through in medical school. And this obviously can go further into the future when you're practicing medicine.
Thank you so much, Alex, for that detail. I think that a lot of what you just mentioned in those statements goes back to what Dr. Marion McCrary mentioned in her session on how to design a sustainable and flourishing career. So I think that that's really nice. We're going to go ahead and move forward with our next presentation. John and Ryan and Margaret Ann, if you would go ahead and share your screen, and we will get ready to go for our next presentation on Healthy Harvest on Wheels. Again, our agenda is in the chat box, so we'll turn it over to John.
All right. So, hi, everyone. My name is John, and together with Margaret Ann and Ryan, we will be presenting Healthy Harvest on Wheels, bringing fresh and healthy food to Scotland County's pediatric population. Oop, I'm having some issues. oops, sorry. So this is our team here. To start us off, I just want you to imagine this, that you're a parent of 4 living in rural Scotland County. You're at your 10-year-old's annual checkup visit, and the doctor tells you your child is overweight and needs to improve their nutrition. And you're concerned. You work 2 jobs just to make ends meet, and with long hours, unreliable transportation, and limited health options in your area, you rely on what's cheap and convenient. The odds feel stacked against you. How can you make a change to better your child's future? So let's take a step back and take a look at Scotland County by the numbers. As you can see here, pediatric obesity is a growing concern, and it's a multifactorial issue. It's driven by limited access to healthy foods, socioeconomic insecurities, and low health literacy. And together, these factors create a deeply complex public health challenge here. But addressing this issue is really critical to the health system and, more importantly, to the health of our community. Pediatric obesity is directly linked to a range of comorbidities and a higher risk of early all-cause mortality. But the most important key takeaway is this, that pediatric obesity and all of its downstream effects is preventable. And with that, I'm going to hand it over to Margaret Ann to share our proposed approach.
Hi, everyone. So when we were thinking about pediatric obesity, 2 major contributors that we considered addressing are poor nutrition and inadequate physical activity. So we chose to focus on poor nutrition and access to nutritious foods for our project. Our project seeks to address these barriers by implementing a mobile farmers market. Mobile markets provide direct access to fresh, affordable, and locally sourced produce in areas with limited access to full-service grocery stores, often referred to as food deserts. By targeting neighborhoods with high rates of childhood obesity and poverty, this initiative aligns with Scotland County's health priorities. The mobile market will operate using a refrigerated vehicle equipped to transport and store fresh produce. Stops will be strategically placed near schools, community centers, and churches to maximize reach to children and families. Partnerships with local farmers and organizations will ensure a steady supply of locally sourced produce. And to enhance community engagement, the market will offer cooking demonstrations, nutrition education, and resources on healthy meal preparation.
Hey y'all. One cool thing about our plan is that this is not a foreign idea. Actually, a program down in Wilmington called Feast Down East is very similar to what we're proposing of a mobile food market where they offer groceries for people to come in and buy food for the week, and then also have recipe cards. They even offer cooking classes. Interesting thing about Feast Down East, they actually partner with Novant hospitals where some clinics are able to offer food prescriptions. And aside from that, with what the intended goal, but the money is going back in the community in the hands of local farmers. So we think this would be a perfect plan for Scotland County, being a more rural county where not only are we addressing the issue we came out to conquer with the pediatric population in Scotland County, but also be giving money right back to local farmers. Some of the plans of implementing this would be not just a solo, like some students come in and try to fix it. They want to get community resources as well. And these are some of the true experts we found in Scotland County that can help see what the health needs are, has some of this been addressed before, and what's the best next step. So not only can we get something started, but also that it can last for many years. The biggest question of most of these projects is where's the money at? So for funding, there are federal grants like the one to the left about where you can apply with more of like a startup, where there's a lump sum of money trying to get you off your feet, and then also kind of inspired from the Feast Down East where they work with Novant Hospital in Wilmington. We'll also be looking with Scotland Memorial Foundation where they do similar charity work as of this, where I think it would be good to keep the money inside the community. Holding questions to the end. I can go ahead and start with like my reflection on the Medical Society leadership program so far. One thing that was interesting is that we took a couple assessments about leadership strengths and weaknesses, And one strength that came through in both my assessments was, then the DISC assessment was more enthusiasm, which I always kind of known, just enthusiastic. And then one that was funny, I found out was humor was a really big strength of mine. And whenever I think of like leadership, these two things aren't usually the first things that come in my mind for like a stereotypical leader. But I found it interesting that these are strengths and they can be used for leadership. Thank y'all.
Hi, everyone. I'm Margaret Ann. I'll go next. Initially, I was thinking about answering this question, reflecting on my DISC profile, because I really did learn so much throughout this experience. But the one I wanted to talk about was writing down my professional and personal goals and how effective that's been. So we worked on a personal development plan, but a theme that we had in many of our sessions was writing down what we were planning to do, writing down our takeaways. And over the course of the last 6 months, I've really been able to see by writing those things down, how effective they can be, how it's something I can come back to. So that was a big takeaway that I really will carry forward.
And let's see, for myself, I think one of the biggest takeaways is just learning the value of just self-reflection. Kind of going off of the whole DISC assessment theme, I learned that I was a C and my strengths lie with analysis and critical thinking and just like trying to get things done right the first time. But I've also recognized that like I have to balance that with taking a step back and learning not to be that limiting reagent on the team when things need to get done quickly, and also just the value of like networking and building more like professional relationships. But I think moving on forward into residency, I'm going to try to make more like periodic times to just like come back, self-reflect, see where I fall short, where I can keep improving on like professional and personal levels.
Very nicely done, everyone. We have a couple of minutes because we don't want to start our next presentation too soon in case there are people who want to log in just for that presentation. So we'll go ahead and open up the floor for questions. We'll start with this last presentation on Healthy Harvest. If anyone has any questions, and then if you have any for refugee and immigrant health, as well as community engagement and maternal outcomes, we'll open up the floor for just a few minutes for questions. Do we see any hands raised?
There were a couple in the chat if you want to
start there? Okay.
Dr. Greenblatt, do you want to unmute or would you like for me to read it?
No, I can read them. Yeah, my DISC profile would say I'm a question asker, maybe. I've actually never done a DISC profile. Anyway, you guys so far tonight, really enjoying your presentations and these great projects. So thank you. I co-chair the Advanced Healthcare Leaders training. So put that in your mind for something to do later. So why don't we start with the obstetrics and the prenatal care? That's Callista, Lindsay, and Mark. As I was hearing about your concerns that you raised about availability and people weren't necessarily happy with the services and how they were treated when they were in the process of having a baby. And I've with my wife, we've had 2 kids. It was a long time ago, but I remember very well what that experience was like. And what you said rang very true. And we're pretty privileged people. Soon, right now, about half of or more of deliveries in North Carolina are funded by Medicaid, and Medicaid is under a huge threat right now. So just how do you think about how that might affect availability of services and also maybe the way that they're delivered with an increasingly strained OB and prenatal care environment? So it's kind of a hard question.
I think it's one that we kind of addressed. And in doing our research, one of our subject matter experts was Dr. Kelly Holder. She's the medical director for the L&D unit in Chatham County. That's kind of been the flower, if you will, for all the things been going on. It's challenging. And they've adapted a kind of, instead of changing policy so much as trying to find financial solutions that are a little more creative. And what they've done is some of these ancillary services that they couldn't necessarily support, subsidizing with the public health department. An example being breastfeeding services, not only postnatally, but prenatally as well. And a part of the family planning process was co-sharing the cost of that provider so that they might not be able to provide that service every day of the week, but they could load a morning or an afternoon once a week or every 2 weeks to be able to provide that service. and in that way reduce the financial cost. Anytime money goes away and falls out of the system, access will decrease. I think that if nothing else, policy needs to be reflective of the people demographics that we serve, and in what way we can find the need and find a new solution to it, because the system right now is broken.
Thank you, Mark. Yeah. I wonder if Callista or Lindsay have anything that they would add or a different perspective on that.
They're a team and they all kind of think the same way. That's wonderful. Nesreen
Thank
and
you.
Alex, there is a question from Dr. Greenblatt in the chat. Can you, either one of you, respond to his question in the chat about how do we both understand and make available a range of effective treatments?
Yeah, I can answer it. I looked at it. I think it's a great question. So I think overall, when it comes to, I couldn't tell if your question was specific for PTSD or just mental health conditions in general, but I think the answer would be the same. When it comes to approaching mental health, it's, across disciplines, it's kind of universally agreed that you always want to start with medication approaches. And so it's a universally agreed thing to start with therapy, start with psychology, start with therapists, start there, and then kind of progress to psychiatry as necessary, and as needed. So that's just something that is, a good practice to start with. With the centralized hub, the goal would be to provide those resources for both psychologists, therapists, and for psychiatrists, and to tailor the recommendations based on the community they're from, because it can differ. A Latino immigrant who is coming with their own experiences and traumas is going to carry a different experiences than someone who's coming from Syria. And that's why there are different therapists and different psychiatrists who actually have specialized in those unique areas that we would want to kind of direct and use individualized resources towards. So to answer your question, it really would be kind of coming together, sharing the existing expertise on what options there are, who's best to, address these issues based on your lived experiences, and kind of tailor the resources to them. I hope that answers your question. If you have a follow-up question, feel free to drop it in the chat.
Thank you. That was great. Very thoughtful. I think Monisha is moving us into our next.
Thank you so much. And so we're ready. Kat, if you'd go ahead and start. Thank you so much.
Okay, just a sec. Okay, hello everyone. Today we'll be talking about nursing shortage and in professional burnout. And this is our team. So North Carolina is currently facing a severe nursing shortage, projected to reach about 12,500 by 2033. With nurse to population ratio of roughly 10 to 1,000, it is equivalent to only about 80 nurses taking care of every 100 patients. In addition to that, a 2021 article from NurseCast projects that by 2033, the largest concentration of registered nurses will be needed in hospitals. So this will lead to almost 10,000 open RN positions. So notably, the Wake area region, including our region, Raleigh-Durham, is expected to experience the largest shortages, as you can see there on the map in bright red color. So as you can imagine, this chronic understaffing creates a ripple effect. It forces healthcare providers to work longer hours and take on extra responsibilities, which heightens stress and ultimately leads to burnout, a work-related syndrome marked by extreme tiredness, cynicism, and feeling of unaccomplishment. In 2022, National Academy of Medicine reported that burnout had reached crisis levels among U.S. healthcare workforce. Between 35 and 54% of nurses and physicians, as well as between 45 and 60% of medical students and residents reported experiencing symptom of burnout. And it is crucial to note that this issue extends beyond nursing. When nurses overwhelmed, the workload shifts to other primary care staff, such as physicians and physical therapists, further exacerbating burnout and compromising care quality.
Research has proven that healthcare burnout has had detrimental effects on not just healthcare staff, but everyone a part of healthcare as a whole, causing a negative impact on the healthcare system. And essentially, who loses in the end is patients, leading to poor patient outcomes. This diagram was published by the US Surgeon Attorney General, which highlights the downstream effects that burnout has on individuals, all participants of healthcare. And looking in on this graph, at a larger scale, a recent survey that was conducted by Formedics identified that understaffing and the increase of patient assignments were the primary contributors to burnout. Findings that align with both state and as well as national data. I will note also that we're tuning in on is that the management and work environment also score notably high with 13% respectively of responses. Similarly, we did conduct a similar survey amongst nurses who are employed at Duke entities and found that our results actually indicated that management practices as well as workplace culture were the leading causes for stress and burnout amongst staff.
On the topic of possible solutions, we're covering them from two lenses. The first is at the organizational level. We're proposing certain policy changes, starting with expanding on the job training opportunities for entry-level positions, which is ensuring that they're trained to meet the standards of the organization employing them and the needs of the population they serve. Next, in light of the administrative burden that providers experience, fostering an open line of communication between administrative teams and clinical teams can go a long way in helping providers feel heard and supported, which we kept seeing are some of the foundations of burnout. And similarly, administrative and clinical teams can have conflicting priorities, but institutions should not be sacrificing quality of care in the name of efficiency. And lastly, Dr. McHugh, an emergency medicine physician and subject matter expert we consulted for this research, spoke at length of a local network of physicians that made themselves available to be on call in order to fill in for colleagues that needed a day off on short notice at their emergency department, and the significant difference that made for all members of the team. So fostering supportive work environments matters, and it makes a considerable difference where burnout is concerned. The second lens consists of legislative action at the state level. These changes would be aimed at promoting consolidation of training and education standards. So currently, a nurse's scope of practice can vary considerably between institutions. We found that this frequently poses an obstacle to adequate staffing because nurses don't feel they're fully utilizing their skills. And where legislation can help is building upon existing standards to promote clearly defined guidelines within institutions across the state, for example. Next, there was a considerable shift toward travel nursing throughout the pandemic that has yet to entirely return to normal. We believe that through legislation, institutions can be encouraged or incentivized to provide better compensation and benefits aimed at hiring and retaining staff in the long term. And lastly, now more than ever, it is vital that we advocate for protections for healthcare workers across the board. It's something that needs to be implemented. And while one could argue that there's a very idealistic aspect to the solutions that we're exploring here, it's worth pointing out that we sought to research this topic because healthcare as it currently operates is not sustainable. This is evidenced by the growing rates of burnout we're seeing among healthcare providers and the worsening workforce shortages that we explored throughout this presentation. So advocacy and activism require a goal, and this is ours, and we hope will be yours as you advance your careers and find yourselves leading healthcare teams and being in a position to enact meaningful change by challenging the status quo. These are the subject matter experts that we were able to consult for this presentation. And these are our references. Thank you so much for your time. Now, I'll get started with answering the question about the insight that we gained. So my most valuable insight was this validation I got from my DISC profile that I care about the people around me and I care about their experience and well-being. In the past, this would manifest as lots of managing interpersonal conflicts within teams I was in, or often foregoing an opportunity to speak up or stand up for something I felt was important in the name of preserving this sense of peace or harmony within a team. And through this long process of self-reflection that FHL facilitated, I was able to explore things I was giving up in order to maintain that peace. It often came down to my own values, preferences, ideas, and sometimes even my integrity. I've gotten plenty of practice lately, ranging from my personal relationships to even working on this project, where I was able to tactfully and meaningfully argue, or as I would call it, advocate for the things that I feel really strongly about. And I'm really grateful for that.
So I guess I'll pick up where Hugo left off. So people talked about disc profile so much. Here we go, disc. Reflecting on my leadership journey, I've come to truly appreciate the importance of learning and leaning into my character strength to foster collaboration and growth, which I also learned from my own disc profile, which I am D, working closely with my team and hearing their feedback has taught me so much about myself and about my team. So, plus the lessons that I've learned from our FHL sessions were really useful, and I think they're as tools in our bucket, I guess, to deal with some of the things that we might not um, haven't known how to handle in our personality. And now we have these tools to meaningfully utilize in interpersonal connections and in teamwork. So I would say this journey hasn't just sharpened my skills, it's just also deepened my appreciation for the unique strength each team member brings to the table. And I encourage everyone to embrace their unique strength and seek feedback from their peers, because I believe this process is exactly how we truly grow as leaders.
I would say for me, I took a lot of things from this program, but more so working with a group. I'm an I style, so I'm used to going with the flow, but I had the privilege of working with someone who's an S style, someone who's a D style. And you have someone who's more level-headed, lax, and then you have someone, who's holding me accountable. Each of them held me accountable, but I took with working with different leadership styles and learning how to respond, and um, I do well with accountability. What I will say, what I want to work on is we took an assessment maybe like our last session or the session before, and it just confirmed that I pride myself on humor, I pride myself on being very spiritual and trying to make everyone feel comfortable. But in knowing that, I have to become more self-aware as what is it that need to work on in order to be a better leader, as far as like, I don't oftentimes want to take the lead, but why is that? And knowing that I actually can if I just, learn how to have a good balance between what I'm good at and what I'm afraid to, kind of pursue and work on.
Thank you so much, Jules, Kat, and Hugo. We appreciate those thorough comments. And we are now going to go ahead and jump into our next presentation. Thank you, Caitlin.
Great. Well, we appreciate everyone's attention. Our group is focusing on fostering diversity in medical education, addressing microaggressions for inclusive growth. Here is our team. And so we came up with a definition. What is a microaggression? Racial microaggressions are brief and commonplace daily verbal, behavioral, and environmental indignities, whether intentional or unintentional, that communicate hostile, derogatory, or negative racial slights and insults to target the person or group. And as a group, we researched 3 different types, but really the heart of this presentation is being able to recognize them. And so we have a few examples. But I want you to put a memo. Your name is too hard to pronounce. Can I call you Mary? What are you? You're really pretty for someone so dark. What do your people think about that? You don't act like a normal Black person. Why do you sound so white? You speak English so well. You're not like other Muslim people. Where are you from? Where are you really from? No, where are you really, really from? Microaggressions may seem small, but their impact isn't. Recognizing them is the first step towards meaningful change.
So some obstacles that we found to fostering diversity in medical education include financial barriers, transportation issues, workforce shortages, limited student mentors, and government policy. So today we'd like to focus on government policy because of recent changes within the government with relation to DEI initiatives. DEI initiatives throughout the federal government and its contractors have become illegal in an effort to, quote, restore merit-based hiring and promotions. The federal-led removal of DEI initiatives creates a hostile learning and working environment because it outlaws efforts to make minorities of any kind feel included. This affects higher education because public schools receive a lot of federal funding. So many North Carolina schools, including Western Carolina and ECU, have dismantled their DEI initiatives or moved them under the umbrella of student life. Private schools, however, receive most of their funding from tuition and private donors. This makes them a great setting for the solutions proposed by our group today.
Creativity is key to finding a solution. First, we need to look at what is working within the system. Our research showed that mentoring programs are one way to make this happen. Good mentoring programs are facilitative and developmental, but we know that requires adequate time, mutual support, and willingness to facilitate this relationship. Mentoring programs such as Prescribe It Forward are already in place. This program connects diverse students with mentors to foster guidance and support through their medical education. The journey of becoming a healthcare professional is already challenging, but students from underrepresented backgrounds, that path can be even steeper. How do we bridge that gap and ensure that all aspiring doctors have the support they need? The answer lies in mentorship. Just a little story about me. Applying to medical school was very rough on me because I had no mentors to ask questions. I tried to change that by mentoring other students. I now have 8 students under my wing who I check in on a quarterly basis. It's so gratifying to have someone who's in your shoes to guide you through. And hopefully the cycle continues. My question to you is, if someone has ever helped you along the journey, why not be that person for someone else?
Hopefully by now you agree that increasing representation is essential not only for equity, but also for improving patient outcomes and addressing healthcare disparities. One of the most effective ways to foster diversity is through pipeline programs, which provide structured pathways for underrepresented students to enter and succeed in medical careers. A 2023 systematic review found that 80% of institutions with a pipeline program reported increased enrollment of underrepresented students. This statistic highlights the real impact of investing in long-term solutions for diversity. A few examples of successful pipeline programs: Tennessee State University and Belmont University's partnership. As of February 2025, TSU, a historically Black college, has partnered with Belmont University to create an accelerated 7-year medical school pathway for TSU students. This initiative is not just about getting students into medical school, it's about creating a sustainable pathway for diverse physicians who are committed to serving underserved communities. Another great example is the MED program at UNC, which provides a structured summer curriculum designed for individuals who have faced barriers such as lack of resources, mentorship, or access. The goal of the MED program is to ensure and enhance students' academic preparedness and increase their chances of getting accepted into medical school while ensuring their success once they're there. Lastly, many institutions also offer summer or year-round programs for high school students from disadvantaged backgrounds. These programs provide exposure to careers in medicine, mentorship from professionals, and often scholarship opportunities to help ease financial barriers. Early exposure is crucial. It allows students to see themselves in these roles and equips them with the tools they need to succeed. In conclusion, pipeline programs and mentorship programs are proven effective solutions to increasing diversity in medicine. They break down systemic barriers, offer academic support, and create clear, structured pathways for underrepresented students to achieve their dreams of becoming physicians. As we continue working toward a more equitable healthcare system, expanding these programs will be the key to ensuring that the next generation of medical professionals truly represents the diverse populations they serve. Here are references. Thank you so much. We'll begin answering our reflection questions.
So I'll start. Reflecting on my leadership journey, I gained a lot of valuable experience on how to be a flexible leader. A lot of life has happened to me during the course of these past 6 months, and growing how to be patient and gracious with myself as a leader, I found a strength in being able to stay grounded under that pressure so that my group members could feel heard, valued, and respected.
So I can answer. We did the DISC profile, which kind of told us a little bit about our leadership style. And actually, when I got mine back, some of the things in it I didn't completely agree with. My main style, which was D, which is kind of a leader that takes charge. But I also had a bit of C, which kind of explained some of the reasons why I would feel a little uncomfortable in big groups. But I learned that by forming connections with my peers, I was able to feel a lot more comfortable. And I learned the importance of taking care of yourself in addition to the importance of the work that we do, and that collaborating with my peers and my mentors really helps me to feel re-energized.
For me, one of my most valuable insight that I've gained is recognizing my ability to let others lead. This has shown me that my natural preference is to listen and analyze before I act, and that is my real strength, especially in leadership. This helped me build that trust that we have as a group. I think we have a very strong group, and create that supportive environment where challenges is met with some clarity and confidence, and to be able to not only present and do a great job at a group project, but also moving forward.
And one of the most valuable insights I gained during this program is the importance of flexibility and collaboration in leadership. Working alongside a group of busy, dedicated medical students and professionals taught me that strong leadership isn't always about sticking rigidly to a plan, as much as I would like, but about being responsive to the team's needs. I learned how important it was to just trust each other's strengths, communicate early and clearly when conflicts come up as life happens, and to offer support when someone needs coverage. This experience helped me to better understand how I contribute to a team, not just by leading, but by being a reliable and adaptable teammate who helps to create an environment of mutual respect and shared responsibility. Thank you so much.
Thank you so much to the team focusing on fostering diversity. We will now move into our final presentation on healthcare mergers and acquisitions. We're going to go ahead and ask Josh if he would share his screen. And so what we'll do is we'll have Josh and Caroline present, and then we'll come back and take questions from the last few presentations, and then we'll wrap up with our graduation conversations, and we'll go from there. Thank you, Josh.
Thank you, Manisha. So yeah, we'll be presenting on healthcare mergers and acquisitions. Let's see, a little bit about our team. I myself am Josh Morningstar. I'm a first-year medical student at UNC School of Medicine, and my partner, Caroline Bate, is a dental student at High Point University School of Dental Medicine. Getting into the issue and problem that we're presenting here, healthcare mergers are a state and nationwide occurrence and issue, which have a lot of hospital and patient level effects, including but not limited to staffing, services, safety, and then the patient level care availability, cost, and quality. But to get a little bit more into healthcare mergers themselves, healthcare mergers are performed oftentimes in the setting of hospitals looking to grow, hospitals maybe facing bankruptcy or financial issues, and a plethora of other reasons. And they are associated with plenty of positive outcomes, but really what we're here to focus on is the negative and how to approach that moving forward. Looking at nationwide trends in hospital mergers over the last decade, as you can see from 2012 to 17, there was a pretty steady increase in the number of hospitals being merged nationwide, and that number has since decreased slightly. With 2023, we're still seeing those 65 hospital mergers occurring. And interestingly, these mergers are oftentimes kind of consolidated into maybe 20, 30 states at most. So really a consolidation of where these mergers are occurring. And I think probably the more important statistic to look at here, or the graph to look at, is the size of the hospitals being acquired. So we're looking at here is the size of the smaller hospital being acquired in mergers in millions of dollars. And so what we can see is that from 2019 to 22, the size of the smaller hospital being acquired nearly tripled. Now, mind you, over that time, there was a decrease in the number of hospitals merging. And so really what this is indicating is a trend towards fewer mergers, but larger mergers, and just a consolidation on consolidation of hospitals, and kind of this creation of hospital conglomerates and monopolistic tendencies. Now in North Carolina, and this is not to report on the quality of any merger, but more so to indicate what's happened in our states. There have been a number of mergers over the past 5 or 6 years, with HCA in Asheville, Atrium and Novant making moves in Charlotte in the southeastern part of the state, and Risant and Cone Health merging in Greensboro. So what does it mean at the hospital level? As mentioned, we're going to have issues with our staffing, our services, and our patient safety. To break it down further, hospital mergers often reduce staffing and are oftentimes come with hiring freezes. So this is going to lead to worsened staff to patient ratios. This can have effect on staff satisfaction as well as patient care, as these mergers have been linked to poor patient experiences, increased treatment intensity, and higher inpatient mortality rates. And I know I'm a little bit out of order here, but rural hospital mergers, which are really where a lot of our mergers are occurring, especially where a lot of our concerning mergers are occurring. These hospital mergers are frequently going to eliminate maternal, neonatal, and surgical services, creating unmet community needs. And this is especially problematic in rural communities when there's not a lot of hospitals available, especially not hospitals that are going to be able to kind of serve to catch those unmet needs. Looking at our patient level, as mentioned, we're going to see decreased choices, increased costs, and lower quality of care. So why is that? Well, hospital mergers are going to reduce the number of independent hospitals, as while eliminating certain service lines, as mentioned. And this is going to increase market power as well as hospitals' bargaining leverage. It's going to cause increased prices for services, which falls back on patients to cover their cost of care. And lastly, but perhaps most importantly, hospital mergers are associated with a modest decline in patient experience. So all of this to essentially paint a picture of we have these trends towards larger and larger mergers, towards hospital conglomerations, large conglomerates, which is going to which can have negative effects at our hospital level, and more importantly, at our patient level, with decreased opportunity for care, increased cost, and decreased satisfaction, all of which we hope to address. And I'll let Caroline speak about that.
So what specifically are we trying to change or improve? It would increase oversight of healthcare mergers by preventing negative impacts on patient care costs, and patients continue to have access to quality care, and control rising healthcare costs and protecting access to healthcare services while also strengthening state regulations. So what should the future or targeted state look like? Overall, preventing negative impacts on patient care and costs. Patients continue to have access to quality care with hospitals maintaining proper staff levels, fair and competitive healthcare market, ensuring that no single hospital systems hold a monopoly. State authorities have stronger regulatory power, and hospitals focus on community health needs rather than profit-driven strategies. And so essentially what we're looking at here is the Washington Keep Our Care Act. They're prohibiting consolidations that diminish care access, and overall, the community involvement is what we're advocating for patient care. And some potential solutions that we have would advocate for policy changes. Essentially, it would be similar to the Washington's Keep Our Care Act to prevent harmful patient awareness and public awareness and community advocacy to support stronger regulations, and to overall emphasize transparency and accountability in hospital acquisitions. And what lens are we looking at? Essentially, we want to advocate for the community and engaging with public and stakeholders to support change. And then these are our references. We're open to any questions. But before that, we would like to dive into reflecting on our leadership journey. For me, most importantly, it was open communication. I've learned to create a space for honest dialogue, whether it's listening to feedback or sharing expectations, building trust, and it drives collaboration. I naturally enjoy connecting with others, and I've found that when I lead with empathy and clarity, teams feel heard, supported, and more motivated to contribute.
Yeah, from my standpoint, I, much like everybody else, felt as though I benefited most from my DISC assessment. My assessment found that I was pretty evenly between a D and a C. And on the chart that points towards challenge, falling right in between results and accuracy. And what that kind of meant as I learned, and I deep down knew it, but really as I learned kind of how to more address it, was that I tend to be negative and overbearing in group settings, focusing on what can be improved rather than focusing on what's good and how to build. So basically, what I've focused on throughout this course, and I think has positively benefited me and will continue to positively benefit me, is to change my lens of focus to focus on what's good here, and to kind of really emphasize improving or emphasize the positives at hand rather than emphasizing the negatives that need to be improved. Thank you all for your time tonight. And I don't know if we have time for questions or anything, but I'll turn the time back over.
Yeah, that was wonderful. Let's go ahead now and open the floor for any questions that you may have, specifically looking at the ones that we just covered, the healthcare mergers, fostering diversity, the chain reaction of nursing shortage, and if you have any questions for Healthy Harvest as well. So let's open up the floor for a few questions for our scholars.
No one will be surprised to know I have a question. So thank you guys. Those were really terrific presentations. And I also enjoyed hearing your own reflections about how you, what you learned from taking this training. I think it's great that you got to do this as a student. So a question for the group that talked about the nursing shortage. That's I think Kat Jules and Hugo. So it seems like we got to think strategically about how do we increase the volume of nurses, and does that mean that we should take existing nursing programs and have them expand and enroll more students? Should we create new nursing programs? And then how do we attract more and different people to the profession? And I put in my comment there, and this is very intentional, like we have so few men who want to become nurses. It's a great career, and it's one that pays well, and you could support your family, and it's science, and it's lots of good things about it. Why don't, how do we get a more diverse student body to consider a nursing career, and then how are we going to train them all? So that's my question.
That's a great question. I would say I'm the nurse in the group. So I'll just say, just from experience and just off the research, I just know from personal experience, the issue is not so much so how do we recruit much nurses? Because you can recruit the nurses. There's an influx of students always coming in through the nursing programs. You have Duke, who partners with their own university for nurses. You have UNC, who partners with their own university for nurses. And then, I mean, there's nursing schools all around the world. So, I mean, when you apply, I mean, it's the beauty of nursing is you'll never be without a job. So the issue is not really recruiting nurses, it's retention. So we come out of school, bushy-tailed, happy to be here. We finally passed our NCLEX. And then we get there and said, oh, this is not what we learned in class. We didn't factor in, oh, being short-staffed. They teach us like our rights, knowing that, we need to make sure we have the right patient, right route medic, basic stuff like that. But what they don't tell you is all the politics that come with nursing that makes people not want to stay there. And what I found, as I spoke earlier about the survey that we did amongst like Duke nurses who work at Duke, various specialties, the issue is not so much so that they dislike their job. That actually scored very high. People are very satisfied with being a nurse. They love being a nurse. The issue is work culture, management, being understaffed. I have five, the max patients I've had is 8 patients. And you can't effectively care for 8 patients when you're only one person. But what I can say about attracting men to the nursing career, I'm seeing a lot more men in the healthcare field as far as nursing goes. And I think they're doing a good job. I can't speak for other states, but North Carolina, I know they'll have like programs within the high school curriculum where you can train to become a CNA in hopes that bridges to, like you guys were talking bridge programs. You can be CNA and then bridge to go on to nursing school. So I think they're pushing that a lot more because it is very much a female dominated career. Um, but I think I don't think nursing programs expansion is gonna fix the issue. I think the issue is more within, and more so is that gonna be up to the hospitals to resolve that issue, or is it more of an issue where legislature needs to come in and kind of take control as far as what should nurses be, what environment should nurses be working in order to best serve not only just nurses but other interprofessional professionals, and will that benefit the patient? I don't know if that answers your question. I did my best.
Thank you, Jill. You answered it and more.
We appreciate the passion, Jules. And we'll go to Dr. Lischke and then Dr. Smith.
You would think I would learn how to unmute for after all this time. Good evening, everybody. What an amazing group of presentations. That was really some powerful stuff. And I could ask about 4 questions to everybody, but the one I'll focus on, because it's one that I've been involved in my 30 years in medical school administration and education stuff, is the pipeline programs. And what it's what we have learned over the years, and it's in the literature, and it's amazing, especially when you have kids who are 7 and 8 years old. If a child does not think math and science is cool and exciting in the 3rd grade, the likelihood of them going into any math and science career, health career or whatnot, is almost 0. And then that only lowers when you don't have, quite frankly, highly educated parents who look like me, who are connected in the community. So I think that we have a lot of work to do on our pipeline programs. A lot of good work has been done. We've learned a lot, and the politics are all getting up in it right now as well, for fear of somebody's not going to be able to get into the thing that they want to do. So I just wanted to make that comment. And the other one on the mergers, I'll make a quick question on that. And I saw Alan Skipper on here. Did I not? I haven't seen that rascal in 20 years. But back in the day, when there were 100 different hospital systems in the state of North Carolina, it was a very clear regulation and funding, government funding, to get that down to 6 or 7. And fast forward 20 years later, guess where we are? We're down to 6 or 7, and struggling when it's 6 and 7. So I think that those are just kind of some thoughts I had, but what an amazing group of people. And I think I'm going to be talking to you here in a minute. So thank you.
Thank you. Dr. Smith?
Congratulations to everyone. Excellent work. I've been impressed listening to the presentations. The question that I had actually does deal with the mergers. With the physician and provider, whether that's nursing and our healthcare teams having such dissatisfaction when mergers occur and patients don't seem to be as happy about it, what is the chance of us actually moving towards the independent practices, those that are able to establish themselves and actually perform in a way that they feel healthcare should be delivered? Was that ever contemplated? Was there any discussion for that possibly happening?
I don't think that was a direct focus of our project, but in talking with a professional within the field, the kind of comment that he made was that we're seeing a reduction too in those independent practices. Not just the hospitals kind of condensing, but that to be an independent practicer in the state or in the nation with kind of trends in Medicare, it's becoming harder, and that as these hospital systems continue to grow, they have the resources that not everybody else does, and they can just kind of eat up the little guys, the independents. So I think that for someone to take that step and to do it is a great effort, and really does allow them to have the practice that they want and the emphasis that they desire within their practice for satisfaction both at the patient and provider level. But I think kind of in our current financial and healthcare ecosystem, I don't know how feasible that is. I hope that was somewhat on par with what you're asking.
I think we have time for one more question.
Or comment.
Okay. I'll actually jump in then. I wanted to ask a question to Tamara, Sarah, Caitlin, and Sheila. Why did your team decide to narrow your focus to Black, Indigenous, and people of color for your presentation on microaggressions?
Yeah, we really appreciate this question because of something we thought about a lot. And we chose to focus specifically on Black, Indigenous, and people of color because their lived experiences in healthcare are uniquely shaped by historical and systemic inequities like redlining, segregation, and limited access to quality care. In our research, we found this write-up called The Color of Medicine by John Ukadike, and he said that you may refuse to see our differences, but that doesn't mean our patients do. And so we were thinking around this idea that treating everyone equally isn't the same as treating everyone equitably. Listening to stories of BIPOC patients and acknowledging how race impacts their care and confronting the microaggressions they face is necessary for building truly inclusive and effective healthcare. And that's why we're naming race, and that's why we're bringing it to the conversation.
Thank you, Sarah. That was a very good answer. I appreciated some of the quotes that you just mentioned. I'm going to go ahead and I hesitate because I have one other question, but I just want to make sure I keep my eye on the time. For Kat, Jules, and Hugo, do you believe that legislative action will be more effective than organizational initiatives in solving the healthcare workforce that you alluded to in your presentation?
So thinking about that, I believe that through our work on the project, it's not one or the other. It looks as though best solution would be having both sides coming to some sort of agreement or solution, because what we've seen in the past is either legislation is pushing healthcare hospitals, entities to do something, and then unintentionally we see some consequences that are not plausible, not good, or the other side, or hospitals are doing half measures, or that are not helpful in the size of the issue that we have. So as it stands now, with the shortage of nursing and how big the issue is, the best solution for the future would be for legislative bodies and for the healthcare bodies to be in the dialogue. So.
Very
And
nice.
just to
Thank you,
piggyback
Kat.
off, ooh, sorry.
Oh, okay. Thank you
Just to
so much.
You good. Can I piggyback off of what she said?
Mhm.
Real quick, just to piggyback off of what Kat is saying, I think it'd just be important for, like she's saying, to integrate the two together. But I think the big thing will be not only the integration part, but for the healthcare entity itself to actually enact what is in place by legislature. Because, I mean, if you're a perfect rule follower, by all means, great. But we know in healthcare, especially with COVID, there are no rules. I mean, you get what you get. If there's patients to be seen, you have to see them regardless of what the law says the patient load is supposed to be for. But if that person needs emergent help, we have to help them. So I think it's more so, like she's saying, the integration and the hospitals taking it, leading it up to them and making sure that it's actually being followed.
Thank you so much, Jules, and we appreciate your perspective. I loved it when you said, I'm a nurse, so I'll kind of jump in there and answer that. So thank you so much to that group. Can we take a moment and let's just give a round of applause to all of our scholars that were participating in our program? Round of applause. Thank you. Thank you. We are so proud of all the work that they have done in such a short period of time. We are appreciative of the time, effort, and energy that all of them put forth. And we especially recognize that their clinical schedules are very full. I think Alex alluded to that. Other people talked about how busy they were, but it was so nice for them to recognize that leadership skills are not something extra. Leadership skills are there to help you gain some additional skills, to help you do your work more efficiently. It's not an add-on. It should be a part of the work that you do every day. And if we take a moment and reflect back on some of the things that people mentioned that they gained from this program as a part of their leadership journey, the DISC assessment, a couple people slightly mentioned the behavioral assessment that we did to recognize your top 5 or 6 strengths. If you look at all those things, you see how they are going to help an individual move from that student level into their professional career and into a position of leadership. This is my first year being involved with this program, and so I am very grateful that I had the opportunity to get to know these individuals. In the last few minutes, I just wanted to kind of share with you some of the overall curriculum. Those of you who are in the audience and may not be intimately familiar with our program, these are some of the things that these individuals covered during this 6-month period. I'm going to go ahead and take a moment to have some closing comments, and I'd like to hear first from Dr. Lischke, who is with Northwest AHEC that provided some of the funding for this program. And then followed by Dr. Lischke, we will go to Erica, my colleague, who has more years of experience working with these students. And so, Dr. Lischke, we'll turn it over to you.
Hey, thanks again, everybody. Again, phenomenal presentations. And I think you need to be incredibly proud of yourselves, because what you just did was not a requirement. It was not part of the curriculum that is already packed. And what I will tell you, after, again, 30 years of being in medical school education roles, mostly here at Wake Forest, I've been privileged to have some of those self-assessments done over the years. And they are thousands and thousands and thousands of dollars worth of stuff that you got, which I think you just need to grasp onto it. The Northwest AHEC started in this space because a colleague here at Wake Forest, Roy Stroud, Dr. Stroud, put this together, and we went to lunch, and the next thing you know, I'm trying to find funding for it. So just beware if Dr. Stroud wants to go to lunch with you. Anyhow, it is a congratulations. The leadership stuff doesn't stop, and I get really irritated when I hear, I won't mention names, but some colleagues declare this stuff that you all are doing are the soft skills. And there's no soft skill in this. This is critical skills, because you have to take care of yourself. You have to find that work balance. We don't need any more burnout. There's enough going on in healthcare that we don't need good people, dedicated people feeling totally beat up so much that the only option is to quit. So thank you for participating in this. It has been an awesome, I think we've been doing this for 4 or 5 years now. So it's got some traction under it. So congratulations. And the other thing that I'll just say is don't lose connection with anybody you met during this process. Take down names, take down numbers, email addresses. I hear from students who graduated 10 years ago from Wake Forest for stuff, and I'm like, of course I'll help you. Here's what I know. So add my name to that list if you would like. Be happy to do that. So I will then pass it on to Erica, the one in charge.
I'm not sure about the one in charge, but I am the one that behind the scenes, hopefully helping keep the ship running with the smaller details. But I do want to echo everything that Dr. Lishke said, Monisha as well, and just say to the future healthcare leaders of this 2025 cohort, you all are the initial cohort of this new academy, but it is not new to any of the folks that are here supporting you under this KNOF Institute umbrella. And so I want to say to you, your journey with our academy, it ends now, but it does not end completely as far as those relationships go. We have given you all the tools that you need to be successful and hopefully be in a space where you feel like leadership is something that comes naturally to you because you do have the tools. You had the tools before you got here. We just showed you how to use them, if you will. So now you stand at this intersection of where we feel like your clinical excellence and leadership will meet. And it doesn't mean that you have to pick a road. It pretty much means that, hey, enjoy and embrace both of those paths and be okay with going down both of those roads. And sometimes in a space of figuring out your own road to take. Step outside of that comfort box. Step outside of what's the norm, if you will, for that beaten path. And remember the strength that you found in learning about yourself in your DIS sessions and some of the other sessions, talking with Jonathan Vihar and some of the other people that came through to talk to you about presentation skills. Use those tools in your tool belts to keep those collaborations, not just with the healthcare teams that you work with, but the patients that you serve, the communities that you're involved with. Don't just go within those four walls of your organization. Put your head down and think about just the leadership there. It works when you're in your car and you're outside of those spaces. So keep that in mind. Keep your vision as your priority thing in front of your face. The ability to pull your teams together. Think about your disc colors. Think about the things that you learn. And I'm sorry, I have a fur baby on the floor that wants to speak to you all too. So just know he's supporting you as well. But keep your commitment to leadership at the front of your mind as you do this great work that you're doing. And again, congratulations to you all. You are the inaugural class of our future healthcare leaders of our NCMS Academy. And if you're wanting to do more with leadership, as Dr. Greenblatt mentioned earlier, we'll take you in our advanced program. We'll also take you in your executive program, and you can come back and serve on our NCMS boards like Dr. Smith and others that are here. So Monisha, I give it back to you.
Thank you both so much for speaking up. I just want to say thank you to all of you for going on this journey with us. I am so appreciative of everything that you've learned and that you've put into your toolbox, and hopefully it will carry you forward. If you need anything from us, please reach out to the North Carolina Medical Society, reach out to me and Erica. But in closing, we will send you information about your certificate of completion. We'll also have a final evaluation for our program, and just be happy and healthy as you move forward. Thank you all for attending. To our audience members, thank you to the scholars for all of your hard work. And Eric and I will stay on for just a few minutes in case you have any questions, comments, or concerns. But thank you all. Take care.
Congratulations, everybody. Nice job.
Thank you so much to everyone.
Thank you. Thank you.
Take care.
Thank you.
Thank you, guys. It's been a pleasure getting to know and work with all of you. Bye.
Hugo, we enjoyed it, and we appreciate the comments that you made. And I think when you were speaking, when everybody was talking about what they got from their disc, I was nodding because I was like, yes, I see that. Thank you so much. We look forward to hearing more from you.
Absolutely. Bye-bye.
Take care.